Thank you. I thank the organizers of Midterm ISOT for inviting me here. And the topic today is past and active tuberculosis in deceased donor. So the outline will be extent of the problem, the international figures, the Indian data, diagnostic dilemmas, therapeutic issues, factors influencing our decision process, some algorithm, and some take-home points. Mycobacterium tuberculosis has been there with us since times immemorial, and there have been, in Egyptian mummies, we have found the evidence of skeletal TB, and in Temple Arc of Konark and Ajanta, you will find the pot spine. The ancient term kubja means pot spine or hunchback, and the first written evidences have come from Egyptian writing and Chinese writing since BC 1300. So it's very, very old disease. Solid organ transplants have high risk, but majority of post-transplant TB is secondary activation in the recipients, but transmission through allograft is possible. But how do you define it? And once you define, how do you deal with it? The extent of the problem is quite high. It's about 1% in Germany, but up to 13% in India. There are no approved assays to diagnose TB in donors, so it is critical to rely on donor history and donor assessment. In disease donor transplant, invariably, the appropriate culture reports will be available long after the transplants are done. The organ procurement and transplantation network policy mandates that reporting of donor culture from the transplant center will come to the transplant center within 24 hours of its availability. So how do we define the donor-derived TB? Proven transmission, or it must include all of this. So first, positive lab evidence of tuberculosis infection in the donor, then positive lab incidence in recipient, then other organs from the same donor, and possible demonstration of same clonality. So all these are very, very stringent criteria or may not be possible in all fulfilled. So there is something called as probable TB transmission, where you have MTB in the index recipient and at least one of them, that is positive lab evidence of MTB in the donor or lab evidence of tuberculosis in at least one other organ recipient from the same donor. And it all includes that there should be no pre-transplant tuberculosis in the recipient. The possible transmission is our index patient has TB and there is some possibility that it could be there in the donor, but we do not have a positive data. There are some international figures of tuberculosis in organs. So in lung, it is highest, followed by kidney. This is from California, and this is the Indian data. There have been from SGPGI, AIMS, CMC, JIPMER, and the data is also telling us that what are the various presentations. What are the diagnostic issues? See, we have lots and lots of diversity in population of possible organ donors. It makes the TB screening in donor essential. But how do we do it? We do current screening, current presentation is donor for latent and active TB. We do history, physical examination, thoracic imaging. For live donors, we can do tuberculin skin testing and interferon gamma release assays. But what do we do about disease donors? So in disease donors, we will first look for the history, the prior TB history, history of active tuberculosis, physical examination. We'll try for cultures, we may not get them. We'll do a thoracic imaging, HRCT and chest X-ray. We'll look for the old apical granulomas, lesions, infiltrates. We'll try for IGRA and gene expert. But all donors might have some abnormal lung findings which are not related to the tuberculosis cause. So what does that lead us? It leads to interferon gamma release assays. So what is interferon gamma release assay? When interferons are exposed, when lymphocytes are exposed to Mycobacterium tuberculosis, to the antigen ES86 and CFP10, then the interferon gamma is released and it is quantified. Why these two antigens are chosen? Because they are distinguishable as from BCG strain as well as from most non-pathogenic bacteria. There are two tests which are available. One is quantiferon TB gold and one is T-spot TB. Quantiferon TB gold, which is commercially available, it costs about 3,000 rupees. The results are available in less than 24 hours, but it has got indeterminate results in immunosuppressed patients. Lymphopenia may affect the test and is not evaluated in deceased donors. T-spot TB, well, it is very recently got available in India and was announced in the Microcon in Lucknow in November 23, not widely available as of today. The advantage is that lymphopenia may not affect the result of this test, but it is not yet evaluated in diseased donors. So what are the potential issues? There is no data on IGRA utility in diseased donor population or similar population like critical care population or head injury patients. It is unknown whether brain death will interfere with IGRA performance, and in donor population with low risk of latent tuberculosis with low pretest probability, it has got very low positive predictive value, which means positive test may just mean a false positive rather than latent tubercular infection, and indeterminate or even positive IGRA shouldn't preclude the donation. What else? We have Gene Expert, which is a nucleic acid amplification test, which is described for sputum. It can be used for other samples other than sputum, like lymph nodes and CSF. It takes about 3 to 4 hours, but it is not used for serum samples. So how do we decide? What do we do? We have one patient who has got diseased donor. He has got active tuberculosis in form of active lesions, positive AFB on culture. We accept or we reject. We recommend reject. And if accepted in dire circumstances, we take informed consent, we involve our IED consultants, and we treat recipient for active tuberculosis. Second scenario, we have clear-cut history of active TB, but he is already on treatment, but the treatment is of short duration or inadequate treatment or incomplete treatment. Then what do? We recommend reject, but if we accept it, we once again take consent, involve ID, and then treat recipient. The third scenario is this patient has taken full course of TB, but has radiological signs in form of apical fibronodular lesions, pleural thickening, calcified nodule or lymph node. Then we get the specimens for AFB smear, culture or molecular diagnostics, and if they come positive, we recommend reject. The fourth scenario is that patient has taken clear-cut history of full course correct TB. We accept we start taking the cultures and other samples. The results are pending. Now we determine whether this is a high-risk donor or a low-risk donor. The high-risk donor means the donor has a history of smoking, has diabetes, is a thin, cachexic, alcoholic, and crowded slum dweller. We recommend reject. But if we accept, once again, we will involve the ID people and will treat recipient for active TB. So till now, we were recommending reject as default. And when we were accepting in dire circumstances, and we were recommending treatment of recipients. The next scenario will be patient has taken clear-cut history of correct TB treatment. We obtain the smears and molecular diagnostics. And if the patient is low risk, what is low risk? He does not have any high risk criteria. Then we recommend accept, and here we consider chemoprophylaxis. Then patient has taken full course of correct TB, but and the results are negative, there's no problem, you accept. Now there is common scenario where patient has imaging suggestive of old TB, apical fibronodular lesions, solitary calcified nodules, other chronically abnormal findings. The molecular diagnostics results are negative. Then should we accept or reject? We should accept, and we should once again consider chemoprophylaxis or treatment. Now we have positive IGRA in the past or positive tuberculin test in the past. Here also, or the imaging has old tuberculosis, then we will get the molecular diagnostic testing, and if they are negative, we'll go ahead with it. And then the last one, where there is nothing clear-cut, there's no history of positive tuberculosis, no latent tuberculosis. This is what we all like to have, and we will accept this organs. So this is the algorithm which I have tried to explain in form of a few case scenarios separately earlier. So what do we suggest? Do not accept organs if donor has active TB, disseminated TB, radiologically active TB, incompletely TB, are correctly treated but now positive smear or molecular test. You may accept organs if donor has history of complete TB treatment and negative results for AFB smear and molecular test, with complete disclosure to family and accepting risk, and along with chemoprophylaxis in the recipient. So how do these recommendations fare in practice? How often do you look for active TB in disease donation? When we have multi-organ donation, especially lung and heart, we will do everything and we'll look for latent tuberculosis. By default, we'll do these tests. How often do you rely on IGRAs? We rely on them many times, but should we? We really do not know. So what are the short-term issues? The short-term issues of perpetual mismatch between organ availability and for transplant and long waiting list. So we have desperate times which will lead to desperate choices. Chemoprophylaxis can be given, but it will lead to a lot of drug-drug interactions, and there is a lot of side effects of anti-TB treatments. Long-term issues will be the latent tuberculosis in recipient versus donor-derived. What is it? We don't know. The long-term effects of anti-TB drugs, they are enzyme inducers. We have levels of steroids and TAC to be monitored. All these lesions will heal with fibrosis, so there will be some problems with the lung function. And we can even induce MDR or even XDR TB with the use of chemoprophylaxis. It can evolve with selection pressure because of chemoprophylaxis and immunocompromised state. What are the apprehensions of treating teams? A disease organ transplant is like a precious baby of the transplant team. So we all are always worried of infections and rejections. And as a whole, we are very, very cautious in accepting organs with potential to transmit infections. But demand for organs far outnumber the availability. Again, desperate time, desperate measures. So we follow the guideline, we treat, and finally we all pray. So to conclude, Mycobacterium tuberculosis is possible to be donor-derived infection in solid organ recipients. Careful search for history and imaging is warranted. Diagnostic molecular tests are available. We do use them judiciously. Reject the organ when reasonable doubt exists, but accept the organ in most situations, and consider chemoprophylaxis or treatment when it is warranted. Thank you.